It's an honor to be here talking in memory of Ken. He really did a lot for this place. And Megan, I know you're worried about me going over 10 minutes, and I can probably talk about hernias for hours, so if the 10 minutes comes up and I'm still blabbing, just cut me off. All right, I want to talk a little bit about robotics for hernia repair. And before we get into that, why don't we just define what a hernia is, for those of you who don't know. A hernia is a hole in our abdominal wall muscle. We all have an abdominal wall that's made up of layers of muscle, and there are some natural weak spots where hernias can form. When we develop a hernia, we'll notice like a bulge or a protrusion, and that bulge can be painful and bothersome. The natural history of hernias is that they typically get larger and more bothersome as time goes on, and the only way to take care of those, unfortunately, is with surgery. We define hernias in many ways, but one of the simplest ways is just by their location. So hernias that occur in the belly button area or incisional hernias we'll sometimes call ventral hernias. Groin hernias we call femoral or inguinal hernias. I can teach you guys how to fix a hernia in 4 easy steps, right? It's first thing we do is we push things back into the abdominal cavity where they belong. Then we close the hole, and we like to restore the native anatomy as best possible. And typically we reinforce our repairs with something called a hernia mesh. Many of you have heard about that, and there's been some bad publicity. But hernia mesh has been around for half a century. It's tried and true, works great, and its main purpose is to decrease the risk of hernia recurrence. So this is a question that I was asked the other day by one of the anesthesiologists is, hey, do we really need a robot to fix every hernia? And I think it's a great question. And I would say no, we don't. But there's certainly some tremendous advantages to using the robot for hernia repair, particularly when it comes to complex abdominal wall reconstruction. But I'd like to go through some of the different hernias in these brief 10 minutes and just describe what the advantages of the robot are. Let's start with groin hernias, the simple inguinal hernia, if you will. So we know for a fact that when we can offer our patients laparoscopic or minimally invasive surgery, that they have better outcomes. They have less acute pain, less chronic pain. So definitely, when it's appropriate, that's the way to go for groin hernias. With the robot, we have improved visualization, better ergonomics. When we're more comfortable, it's better for you, which isn't the only reason to use the robot, but it's one of the reasons to use the robot. Certainly, laparoscopic inguinal repair is an excellent technique, but there are instances where it can be very difficult to do laparoscopic groin surgery. Patients who've had prior prostatectomy, patients who've had C-sections, lower abdominal scars, doing this laparoscopically can be very difficult, and here's where the robot really shines and allows us to offer a minimally invasive approach. For those of us who do complex revision surgery, remove a mesh that's been bothering patients, neurectomies, again, the robot really shines. What about ventral hernias, belly button hernias and hernias in that location? Well, let's look at what we do laparoscopically, which is the most common repair across the United States for ventral hernia. So if we imagine we're in the abdominal cavity with a camera, we're looking down at the intestines, and up above is the abdominal wall. This is what a hernia is. It's a hole in the abdominal wall. We're going to close that hole, and then we'll have to reinforce that using a mesh. For this type of repair, we need something called a composite mesh, which is a special mesh designed to be placed up against the intestines. We don't want it to stick to the intestines, so it has a non-sticky side that faces the intestine, and it has a sticky side that faces the abdominal wall. That mesh has to be a certain size, and then we secure that mesh in place with these little tiny tacks that are made of plastic, and those tacks dissolve over time, but they can cause pain. And the mesh also is in contact with the abdominal viscera, with the organs, so it can cause scar tissue to form and may sometimes be problematic in the future. So what can we do robotically? What's different about the robotic approach? Well, for these smaller defects, we can do something called a robotic TAP, which stands for transabdominal preperitoneal repair. And really what we're doing here is, rather than using the tacks, we're using suturing and minimal fixation, because we're able to bury that mesh in the abdominal wall and use our native anatomy to kind of hide the mesh from touching the organs. And this is what that looks like in live time. You can see on the left side We're working inside. We're kind of peeling down that layer of very fine tissue called peritoneum, and that's where our mesh is going to be placed, so it won't touch the organs. On the right side, you can see we're reducing the hernia. As we continue, this video, the patient also had a groin hernia, so we'll just ignore the left side of the screen and look at the right side of the screen where we're closing that defect. And not only are we closing the defect, but this patient had a separation of the abdominal wall muscles we call diastasis. So we're fixing the diastasis at the same time. We then will reinforce that mesh, again, not using tacks, but minimal fixation, using sutures, and we'll close the peritoneum and use that native tissue layer to cover the mesh so patients have less pain and we don't have to worry about the mesh ever eroding into the organs. What about patients like this? Patients who have these large complex hernias, who've had multiple hernia repairs in the past. They may have previous mesh in place. These patients are often come to us in trouble. They're looking for someone to fix their hernias. And I would say here is where the robot really has made a tremendous advance over the past half a decade. So complex hernias, like we mentioned, these patients require something called abdominal wall component separation. We don't repair them with those 4 easy steps. There's a lot of kind of intricate steps that we need to do to lift the muscles off their attachments and slide them together. So we kind of lift the rectus muscles up, slide them together. We can release the obliques and close the defect. Throughout the world, most patients still undergo open surgery for these large complex hernias. Let's compare the two, and this is our data. We know that for open surgery, and the left side I would say is national data. We know the length of stay is at least 6 days. These patients all have large incisions, sometimes a foot long on their abdomen. They go home with drains in place for sometimes over a month. The wound complication rate is a third of patients will have, and it's a fairly morbid operation, long recovery. With robotics, and again, this is our data, over the past 7 years, we've been doing this. Our length of stay is only 1.8 days. We have 3 to 6 small quarter-inch incisions. Often our patients go home with no drains. We have a 1.5% wound complication rate. We've had no mesh explantations, and really a tremendous advantage to our patients. Another thing that we've been doing, something called eTEP access, and I'm going to go over that briefly, just for purposes of time. But if we can imagine us operating inside the abdominal cavity, we put our camera inside, and it's almost like we're standing in a room. So if you look at the right-sided image, in order to fix the hernia, we kind of have to peel the roof down, fix the hernia, we'll put our mesh up, and then we put the roof back up. So rather than doing that, imagine if we could just drill a hole in the skin or muscle and then work between the layers of the abdominal wall. So this is something that we've been doing here since 2017, something called eTEP access. I think I'll skip the video just for purpose of time, but this is kind of what it looks like. I will skip it though. The benefits of eTEP are, and again, this is hot off the press. We haven't published this yet, but we are submitting it. We've shown eTEP versus the transabdominal approach. Our length of stay is actually 0. Most of our patients are going home the same day. And we've also monitored pain scores and show they have decreased postoperative pain. Looking at outcomes, so I would say this. We are the first center on Long Island to introduce complex abdominal wall reconstruction. We've been doing this since 2015. We're the only abdominal core health center on Long Island, the only high-volume center in the region. We've shown improved outcomes and decreased cost. This we recently published 2 months ago on hernia. This is looking at our long-term outcomes, which really, this is a new technique, so most patients don't have most centers don't have 2, 3, 4-year outcomes. We have over 300 procedures to date. We looked at our first half, 54 patients, and we had a 3% recurrence rate, 1.5% infection rate, no mesh explantations, no bowel injuries, and a very low length of stay. And not only that, we showed that the quality of life for these patients is improved over open surgery. Quick shout out to my colleagues in the Abdominal Core Health Center. Another thing to note, we have, I think, 17 peer-reviewed publications over the past year, and we've presented at 15 different conferences. We have a conference next week for those of you who want to attend. We have 2-day didactics, 1 day all didactic session, the second day is live surgeries. And I believe my 10 minutes is up, so I will thank you guys.